So adrenal cortex disorders, okay? Aldosterone. Aldosterone is going to reabsorb. Well, what makes aldosterone come out is low blood pressure. Okay, really renin, which is going to decrease. So here, let me show you. If you have a decrease in blood pressure, that makes an increase of renin. And then there's a series of things, right? We talked about the renin, angiotensin, aldosterone mechanism, which I won't go into right now. But then that's going to increase aldosterone, which means that this is going to increase or reabsorb sodium. Water will follow, which means blood volume will increase, which means that blood pressure will go up. Does that make sense? Right? Your blood pressure decreases, your renin is going to go up, a series of events happen, that'll make aldosterone go up. Aldosterone from your adrenal cortex is then going to reabsorb sodium. Water is going to follow. That means your blood volume will go up, which means your blood pressure will go up. Right? Does that make sense? But if you're, and like I talked about before, if sodium goes in, does that make the blood more positive, more negative? Nothing. If sodium is going to go back into the blood, get reabsorbed into the blood, does the blood going to get more positive, more negative, or no change? More positive, right? Sodium positive. So we got to fix that too. So what happens here is that aldosterone is also going to decrease or secrete potassium. No, it's not. Same things, meaning like sodium and potassium, but different concept. Okay? So, if you understand that concept, then you already know if there's too much, what's going to happen, and too little, what's going to happen. So if you have too much of it, you have primary hyperaldosteronism, or better known as Conn's disease. Okay? So this is where the adrenal cortex, the place where aldosterone is coming from, that's where the source, that's why we call it primary, because it's coming from the source where aldosterone is coming from. That's where we're going to have some kind of neoplasia there, some kind of tumor growing in. It's going to spit out a lot of aldosterone. We could also have a secondary cause for increase of aldosterone, because I can't say the word. In this case, now look what's going to happen here. You know about the renal artery. The renal artery is going to bring blood to the kidney. But you have stenosis. And we'll get into this when we talk about the urinary system. The stenosis. Stenosis just means narrowing of a blood vessel, or narrowing of something. So now you've got a renal artery that's closing up because atherosclerosis, which we'll talk about, something is closing that up. So now there's less blood flow going there to the kidney. So you're going to decrease the renal blood flow. If you decrease the renal blood flow, you're going to decrease blood pressure. If you decrease blood pressure, then you're going to increase renin, which means you're going to increase aldosterone. And now these people are going to have high blood pressure. It's just going to keep on going until we can fix that renal artery. It's secondary. It's not from the source of where aldosterone is coming from. It's another source that's going to make the aldosterone come out. So if you increase aldosterone, your blood pressure goes up, you got hypertension. So if you have high blood pressure, that means that your sodium is going to go skyrocket up because this is increased. But that means your potassium is going to go skyrocket down. Does that make sense? That's what's going on there. So you have hypernatremia, hypokalemia, which will cause muscle weakness. If you know the function, the only thing you got to memorize is the name, like Conn's disease. But you know the side effects. You know the symptoms, right? a decreased amount of aldosterone, then you already know what's going to happen. A decreased amount, you mean you'll have lower blood pressure, hypotension. You're going to open my door and let all this glucose in. Okay. Okay. Then you get hypotension, but in a case like this, your sodium is going to go down, but your potassium is going to go up because you have a decrease of this. Is that clear? Right? That kind of makes sense. Okay? All right, so let's talk about cortisol. Any questions about aldosterone? Okay, cortisol. Cortisol, we have an excess. Now we're going to talk about if you have too much of cortisol. Now cortisol, remember what cortisol does. When you have okay. When levels of glucose are low, then glucagon kicks in. And it's going to, like I said, you have that big iceberg of glucose called glycogen, and glucagon is going to chip away at that, and little pieces of glucose go into your bloodstream. But that process takes hours to do. So we got to have another mechanism to get glucose in the bloodstream that is much faster than this. You can't be waiting 8 hours when something like, you take one of my exams. You need that glucose to get rushed into the bloodstream to go up to your brain to start thinking. So you need to, or a bear is chasing you. So you need to be able during stress to get that glucose up into your bloodstream quickly. So that's what cortisol is going to do. Cortisol will be able to do that. But if you have too much of this, then we have some problems. When you have too much, we call it Cushing's syndrome. The most common cause of this is corticosteroids. Steroids, prednisone, things that you take by mouth. You take not things, but the pills. And there's a lot of reasons, good reasons for taking these. It's hard for me not to talk about this. I know it's on a pharmacology course, but it's so vital to understand because corticosteroids is basically a synthetic cortisol. And we use it for so many different reasons. And it really is the cause of this disease. Well, one of the causes. So we have two types of Cushing syndrome. We could have an ACTH-dependent Cushing syndrome. Remember, ACTH from the anterior pituitary is going to target the adrenal gland to release cortisol. And sometimes a little aldosterone too, but it's mostly cortisol. So you're going to increase ACTH. So lung cancer, as you've seen it before with PTH, sometimes lung cancer can secrete a PTH-like hormone. It could release or secrete an ADH-like hormone. And in some cases, it could produce an ACTH-like hormone. Why? We don't know. It doesn't. We call that an ectopic source, a source that is coming from some other place than where it should be. Like an ectopic pregnancy is a pregnancy that's in a tube, fallopian tube, not in its normal place like inside the womb. So an ectopic source of ACTH is not from its normal source of the anterior pituitary, but it's coming from some other source, in this case, lung cancer. We could also have an anterior pituitary adenoma that's going to produce ACTH that's going to stimulate the adrenal cortex to release cortisol. If that happens, then we refer to it as Cushing's disease. That's where it gets a little semantics, but it's not just semantics, there is a difference. So Cushing's disease is when the anterior pituitary produces ACTH at a high level due to an adenoma. Cushing syndrome is any kind of increase of Cushing's. I'm sorry, any kind of Cushing syndrome is any kind of increase of cortisol. So we could have ACTH dependent or we could have ACTH independent. In other words, ACTH is not the cause of making all this cortisol come out. And it's pretty reasonable what that is. I know it's all these words here, but when you think about it, it's really the adrenal adrenal gland is becoming hyperplastic or some kind of tumor there that's going to produce all this cortisol. All of that is going to produce that cortisol. Or it could be corticosteroid use, the steroids that you use. And there's a lot of reasons why you would have cortisol, like prednisone and cortisone, all those things do that. So these ACTH won't go up. These will. So this I took from your book. Here's the ACTH reasons. Here's the ACTH independent reasons. So here's ACTH dependent, ACTH independent, and it shows you how you get Cushing syndrome. Okay? So these are the signs. Like I said, it's going to increase sugar. So what's going to happen here is that you get hyperglycemia. So yes, when people have Cushing's disease or Cushing syndrome, they can have at least a temporary reason why they get type 2 diabetes. Because all that, they become hyperglycemic. And like I said, you put too much sugar out there, it's going to stick. It's going to do certain things. Okay? Because you have a lot of glucose in the bloodstream, it has an osmotic kind of pressure. It's going to draw fluid from the it's going to draw fluid from the interstitial fluid area to bring more water into the bloodstream, and that's going to make blood volume go up, which means you're going to have high blood pressure, hypertension. Bones lose substance, you become osteoporosis with that. Your immune system goes down, and that's usually the more common reason why you would be put on corticosteroids. You got allergies, you got lupus, you have any kind of autoimmune disease. These are all, that means your immune system is overactive. So we got to decrease the immune system so that we put on prednisone or corticosteroids. It's a pretty common drug. But we only put them on a short amount of time, 10 days. If you put them on for long term, 3 months, 5 months, 6 months, they're going to start getting Cushing's. They're going to get all these symptoms over here. They have poor collagen formation. So what that means is that their skin, as they get bigger, you're going to have stretch marks because the skin is not going to be able to sustain its architecture. It starts ripping apart and you start seeing these stretch marks. You're going to have increased weight gain. This is an interesting way that the weight is actually distributed on here, is that they usually get this central fat distribution. In other words, the fat usually stays within the trunk area. They get more of a, what we call a moon face. The face gets full like a moon. They usually have a lot of fat goes on their back, and they start getting like this hunchback. Not bones, but actually the fat in their back starts building up. We sometimes call that as buffalo hump. But what happens here is that the legs, since it needs to get other sources to get glucose into the bloodstream, it'll even start breaking down proteins to change that into energy, which means that the legs, the muscles in your legs start getting thinner. So these people, so it's wasting the muscles, so these people actually look like an egg on 2 stilts. It looks like that. You see how her body is? It looks like an egg like this, but look at how thin these legs are. That's why I look at people, I have an idea what's going on. You got that very thin legs over here, but they have this, and they got this moon face that's happening here, the humpback over here, and that's what's happening. Question?
So, I know a lot of people that take like prednisone. They
How long are they on it for? Why? What's a year?
It seemed like it because I can see like.
I'm going to show you pictures.
Like
Maybe that's
on and off.
That's why they got to have some hiatus so that they're not on it for a long time. Because you will have these things, osteoporosis and diabetes. You can't be on it for a long time. Right. But you got to play the pros and the cons. I mean, if they got SLE and their kidneys are shot, then it's better to put them on this medication until we could fix the kidneys.
And lupus.
Yeah, lupus. It depends on the situation. Everyone's a little bit different, but we don't like to put you on for a long time because you start getting these things. See how the face is like a moon face. And that's not so bad. That's more of a cosmetic thing, right? This moon face. Look, even these two people, they're not related, but yet they look very similar. See the stretch marks over here. What happens there? See this is okay before the disease, and then they got this fatty kind of neck area here, up here. So that's buffalo hump. So that's what they look like, and then a year later, that's what they look like. See how the face gets full? It's like a moon. That's what she looked like before, a moon face, and then they get treated, and it's not. This one here, I don't know, do you guys know Jerry Lewis? He just died last year. He was a comedian back in the 50s and 60s, and he does he used to do the Labor Day telethon. I think he's the main person for muscular dystrophy. Anyway, it's just showing you here, this is what he looked like one year, and the following year, you see this moon face? It's like full. Like my parents saw the telethon, they saw what he looked like here, and they said, oh my God, look how much he ate. I could tell right now, that's not from food. Especially after 1 year, that's what he looked like. But I could see, it's a moon face. I said, he's on steroids for something. I'm like, how can you tell? I could tell by the face. And I looked it up, I found out that he had a lung disease, which we'll talk about later. He's got idiopathic lung fibrosis. And that means that the fibroblasts are producing too much collagen fibers to make the lungs very stiff, and you can't breathe. So you decrease the immune system so the fibroblasts don't get overstimulated, and then you can breathe, but then you get this side effect thing. So he was on it for like a year or so, but until they could fix it, this is how he looked. But the doctors had to monitor, make sure he's not getting too much diabetes and so forth. Okay? All right, now if you have a deficiency of cortisol, well, in this case, we call it Addison's disease. Addison's disease, the most common cause of it is an autoimmune disease. It's a disease where you start making antibodies and destroys the adrenal cortex. Okay? There's other reasons like tuberculosis, TB. How does that happen? Well, mostly TB goes up to the lungs, so it doesn't usually go to the adrenals, but it can. If it's in the bloodstream and your immune system is down, it will spread all over the place. It could go in your bone, it could go to the adrenal gland, and will destroy the adrenal gland so much that the cortisol is not going to come out. AIDS, well, a lot of people with AIDS have TB, so if someone's got AIDS, we'll be watching them for this. And metastatic cancer can also go there too. It usually affects the entire adrenal cortex, but mostly cortisol is the one that gets involved. But it's not unlikely to also see that aldosterone and androgens get involved too. But it's usually the cortisol. This is a fatal disease. This is one of the deadliest diseases out there if it's not fixed. One, because of hyperkalemia, which we'll talk about. This will cause a heart attack. The other thing is that there's no cortisol secretion, which means they can't counteract stress. Not just my exam, but stress is anything. Whether you almost get in a car accident, whether you get in a car accident, maybe just an infection, that's stress on the body. Going for surgery, that's stress on the body. So you won't be able to counteract that. And because of that, you die. Okay? So, symptoms of this. Think of what cortisol does and think of the opposite of that. If cortisol makes sugar go up in your bloodstream, well, they're going to have hypoglycemia, right? There's going to be weight loss, muscle weakness. They're not going to be able to tolerate and counteract stress, disease, or surgery, as I just said. They'll have hypotension, right? They'll have hyponatremia because the aldosterone, if that's affected, you're not going to be able to get the sodium back into the bloodstream, which means water's not going to get to the bloodstream, which means you will get hypotension. You're going to have hyperkalemia because it does, remember what aldosterone does, normally it's going to excrete the potassium, but now the potassium is going to go back into the bloodstream. So you're going to have hyperkalemia. This one's an interesting thing. bronze color to the skin. That's sometimes the thing that's going to be picking out to medical professionals. Why do you get this bronze color? It looks like they just had a suntan. This is what happens. Because you have no cortisol coming out, that sends negative feedback to the anterior pituitary to produce ACTH. Does that make sense? Right? Negative feedback. Low amounts of cortisol, negative feedback, we need more cortisol, so ACTH is going to come out. But ACTH is going to come out a whole slew of amounts. Now here's the thing. To make ACTH, I forgot the product. You don't have to worry about it. There's a certain chemical that is needed to make ACTH, and we're going to make a lot of it because we have to make a lot of ACTH. Well, that same product, POM, something like that, there's the same product that we're talking about also is going to make a lot of melanocyte-stimulating hormone. So not only are you going to increase ACTH, you're also going to increase MSH. So what does MSH do? Melanocyte-stimulating hormone. It's going to stimulate the melanocytes to make more melanin, which means you're going to have a darker skin. And that's how they get this. So what does it look like is that. It's got this dark skin. Now that looks like just something like she just went to get a tan. So this patient comes up to me and says, I'm just here for a routine checkup. Oh, I saw you, 2 months ago. Where'd you go? You look good. You just went on I'm not chatting up or anything. I just wanted to see, I started off chatting up, but, she went someplace. Look, she has a tan. Oh, I didn't go anywhere. I just stayed in the house. Yeah, you got tan. Oh, I didn't know. When you look at yourself all the time, you don't realize the changes. But if I saw like this 2 months ago and that's what she looks like now, something's up. And she didn't have a reason to go, not going outside or anything. So that's Addison's disease, okay? And these are all the different things that can happen with Addison, right? JFK had Addison's. They didn't tell anybody until years after his death because you don't want to hear that your president has a disease. What if he dies in prison and it gets out to other countries? Oh, our president's going to die because of the disease. Not a good thing. So we didn't find out until later on they became open with that. So he had that. It was easy to fix. You just add cortisol for the rest of his life. Just get pills or something like that. Okay? Last one on here is adrenal medulla. It's a quick one. Okay? On this one, the only one I want you to know is an excess. You gotta go? You go. Okay. So is an excess amount. This is called Pheochromocytoma, or Pheo for short. If you know that inside the adrenal medulla, it's going to produce catecholamines, and that's a group of substances that we really are calling the epinephrine and norepinephrine. And what happens with this is that if you have an increased amount of epinephrine and norepinephrine, you're going to have severe hypertension. Think of all the things that epinephrine and norepinephrine do, all the flight and flight things. That could lead to stroke. Luckily, this is a benign tumor, meaning it won't spread. However, they could still die from all this epinephrine and norepinephrine. 10% of these will actually become malignant. Okay? So that's the only one you got to worry about with adults. And the last thing on here, it's kind of like a miscellaneous thing, MEN, or multiple endocrine neoplasia syndrome. Basically, it's a genetic thing that we find out that there's certain endocrine cell growth happens in multiple endocrine glands. So in other words, if you have, let's say, something wrong with the thyroid, let's check your other places that you could also maybe have an areas with, because then it's going to be a different treatment. It mainly occurs in younger people, and if it is malignant, because it could be benign or malignant, if it is malignant, it could be very aggressive. So MEN1, which is Werner syndrome, that has the pituitary, so you have some kind of pituitary tumor, parathyroid hyperplasia, you have pancreas, some kind of pancreas tumor, and some gastrin. I kind of use this as saying the 4 Ps. We didn't talk about gastrin so much yet because we didn't get to the GI. Well, gastrin is going to make your hydrochloric acid in your stomach skyrocket up, which is going to cause peptic ulcers. So there's my 4 Ps. Pituitary, parathyroid, pancreas, peptic ulcer disease. That's how I kind of remember it, okay? Then you have another one, MEN 2A, and that's when we have medullary carcinoma of the thyroid, pheo, and parathyroid. And the last one here is 2B. It's the same as this, but without the parathyroid hyperplasia. Okay?